Welcome to the deep dive. Today we're taking on attention deficit hyperactivity disorder, ADHD.
Yeah, it's a big topic.
It really is. And you've given us some really interesting sources. We've got a big picture overview from Stat Pearls, a chapter from the Nelson textbook of pediatrics, and then several PubMed articles looking at, well, how common it is, this whole screen time connection.
Right, a good mix.
Exactly. So our goal here, as always, is to cut through the noise, pull out the key insights, the stuff that really matters, and give everyone listening a solid grasp of what the experts are saying about ADHD.
Get informed quickly but thoroughly.
That's the idea. Get informed without getting totally bogged down.
Ooh.
So let's just dive right in.
Sounds good. You know, it's funny. ADHD feels like such a modern thing, but the idea behind it, it's been around a while.
Oh, really?
Yeah, back in the 1930s, they were talking about something called minimal brain dysfunction.
Huh. Minimal brain dysfunction. Doesn't quite roll off the tongue like ADHD.
Not quite. And the labels, they've really changed over time. Like in the 90s, the DSM-IV, that's the big diagnostic manual.
Right, the Diagnostic and Statistical Manual.
Yeah, that one. It brought ADD and ADHD together under one umbrella, ADHD, but with different ways it could show up, different presentations.
Okay.
And now the ICD-11, which is the International Classification System, it's mostly lined up with the current DSM-5 using ADHD as the main term.
It really shows how our understanding, well, evolves, doesn't it? And you mentioned there's been debate over the years.
Oh, definitely. A lot of controversy surrounding the diagnosis, especially over the last century or so.
But looking at these sources, it feels like there's a much stronger consensus now, at least over the last 30 years.
I'd say so. Pretty strong agreement now that, yes, ADHD is a real condition, and we generally agree on the main symptoms, the defining characteristics.
Okay, good. So let's dig into that.
Yeah.
What are those core characteristics? What actually is ADHD?
Fundamentally, it boils down to ongoing patterns of behavior, specifically levels of inattentiveness, hyperactivity, or impulsivity that are, well, out of step with someone's age or developmental level.
Out of step, like more intense or more frequent than you'd typically expect.
Exactly, a real disconnect.
Okay, so let's unpack those three things. Inattentiveness first. What does that actually look like day to day?
Right, inattentiveness. It can show up in, well, a lot of ways. Maybe someone misses details, makes careless mistakes, schoolwork, chores, that kind of thing. They might find it really hard to stay focused on tasks or even during play. It can look like they're not listening even when you're talking right to them.
Yeah, I can see that.
Following instructions, finishing things, that can be a real struggle. They might avoid tasks that need sustained mental effort.
Like homework or long projects.
Precisely. And then there's the losing things, keys, wallets, homework, tools, being easily distracted, forgetfulness in daily activities.
Wow, okay. That paints a pretty clear picture. It's not just occasional zoning out.
No, it's persistent. And it really gets in the way of things because it points to difficulties with what we call executive functions, those skills for organizing ourselves, managing time, staying on track.
Right, the brain's management system, sort of.
You could put it that way, yeah.
Okay, so that's inattentiveness. What about the other side? Hyperactivity and impulsivity.
Hyperactivity often looks like fidgeting, squirming, can't stay in their seat when they're supposed to.
The classic image, maybe.
Kind of. Lots of running around or climbing when it's not appropriate. For adults, it might feel more like an internal restlessness, like they're always on the go.
Interesting. So it changes a bit with age.
It often does, yeah.
Yeah.
Difficulty playing quietly, always seeming driven by a motor, talking way too much.
Yeah.
Those are also common hyperactive signs.
Okay. And impulsivity.
Impulsivity. That's often blurting out answers before the question's even finished.
Cutting people off.
Yeah, or having real trouble waiting their turn, interrupting conversations, jumping into games or activities without waiting, acting without thinking through consequences.
So it's definitely more than just being energetic or easily bored. These sound like patterns that can really cause problems.
They absolutely can, and that's key for the diagnosis.
Right. Our sources are clear. There are specific criteria you have to meet, aren't there?
Exactly. The DSM-5 criteria, that's mostly what's used, say, several of these symptoms, either inattentive or hyperactive impulsive, had to start before age 12.
Before 12, okay.
And they need to have been present for at least 6 months. And critically, they have to be causing real problems, significant impairment in their social life, school, or work.
Not just a minor annoyance.
No, real impairment. Plus, the symptoms need to show up in more than one setting, like at home and at school, or home and work.
So it's pervasive.
Right. And importantly, you have to rule out that the symptoms aren't better explained by some other mental health condition.
Makes sense. You mentioned the ICD-11 earlier aligning with DSM-5. Any key differences there in the criteria?
Well, the Nelson textbook points out that while ICD-11 agrees on the core features, it's actually less specific about things like the age symptoms had to start, or how long they need to last, or even a minimum number of symptoms.
Interesting. That slight difference could definitely impact how prevalence numbers look in different places, couldn't it?
It certainly could, yeah. Different criteria, different results sometimes.
Now, what happens if ADHD isn't picked up, isn't addressed? What are the potential downstream effects?
Yeah, untreated ADHD, it can lead to some pretty significant struggles later on.
Hmm.
Our sources mention things like difficulties with social relationships, a higher chance of engaging in risky behaviors.
Like substance use?
Potentially, yes.
Uh-huh.
Also, things like job loss for adults, ongoing academic problems. The Nelson textbook specifically mentions issues keeping relationships going, low self-esteem, maybe even more antisocial behaviors, and a higher risk of accidents, too.
Wow. So the impact can be really broad if it's not managed.
It really can. That's why understanding these criteria and recognizing the signs is so important.
And we should remember, it doesn't just disappear when kids grow up, right? Though, maybe it looks different.
That's a crucial point. In adults, yeah, the really obvious running and climbing might fade, but that inner restlessness might still be there. What you often see more clearly in adults are things like chronic procrastination, maybe mood swings or instability, low self-esteem. The core struggles with attention or impulsivity are definitely still present, though.
And it can impact life even outside work or school.
Absolutely. Stat Pearls gives a good example. A stay-at-home parent struggling with organization, time management, just keeping the household running smoothly. That's still significant impairment.
Right. The impact is real, even if the setting changes. And the DSM-5 talks about different presentations, doesn't it?
Yes, three main ones. There's the predominantly inattentive presentation, mostly focus issues. Then predominantly hyperactive impulsive restlessness, acting without thinking. And finally, the combined presentation where someone meets the criteria for both.
Okay, that clarifies the different ways it can show up.
Hmm.
So we're getting a clearer picture of what ADHD is. Now let's shift to why. What causes it? The etiology, the pathophysiology. What do the sources say?
Right, the causes. The big takeaway across all the sources is that it's multifactorial.
Meaning, lots of things contribute.
Exactly. It's a complex mix of genetics and environmental factors. There's no single cause.
Okay. And genetics seems like a big piece.
A very big piece. The Nelson textbook really emphasizes this. Twin studies show incredibly high heritability, somewhere like 70 to 80%.
Wow, 70 to 80%. That's huge.
It really is. And it means that close relatives, siblings, parents of someone with ADHD have a significantly higher risk themselves.
So genes definitely play a major role. Does that mean environment is less important, or is it more like an interaction?
It's more like an interaction. Think of genes loading the gun, maybe an environment potentially pulling the trigger.
Okay, so what environmental factors are we talking about?
Well, we know certain things that happen before birth can increase risk. Prenatal exposure to smoking or alcohol, for instance. Being born prematurely, even what they call late preterm, just a few weeks early, that's linked to higher risk too.
Interesting. Anything else?
The Nelson textbook brings up maternal mental illness during pregnancy. But interestingly, it seems to be the illness itself, not necessarily any treatment the mother received for it, that's linked to the increased ADHD risk in the child.
That's an important distinction to make. So it's not the medication, but the underlying condition.
Seems that way based on the evidence discussed there.
Okay. Now, a lot of people wonder, are there actual visible differences in the brains of people with ADHD? Can you see it on a scan?
Well, yes and no. Research has found some consistent differences using brain imaging. But, and this is really important, these aren't used for diagnosis in a regular doctor's office.
Right. It's more for research understanding.
Exactly. So what they see includes things like dysregulation in how certain brain circuits communicate, especially between the frontal lobes and deeper areas.
The planning and control centers.
Right. Also, slightly smaller volumes in some parts of the cortex and some differences in the cerebellum, that part involved in coordination and timing.
Huh. And there was something about brain development speed.
Yes, a noticeable delay, about 3 years on average, in when the outer layer of the prefrontal cortex reaches its peak thickness.
3 years. That seems significant.
It does suggest a difference in the trajectory of brain maturation.
So tangible differences in brain structure, even if not used for diagnosis. What about brain chemistry? Are neurotransmitters involved?
Yes, definitely. Dopamine and norepinephrine are the key players mentioned in our sources.
The brain's chemical messengers.
Right. The thinking is that an imbalance or dysregulation in how these systems work contributes to ADHD symptoms. For example, some studies find a higher density of dopamine transporters in people with ADHD.
Transporters. Those are the things that clear dopamine away.
Exactly. So if you have more transporters, maybe dopamine gets cleared out too quickly, making it harder for those attention and reward signals to work effectively.
Ah, okay. And that ties into how medications work.
It does. Stimulant medications primarily work by increasing the availability of dopamine and norepinephrine, often by blocking those transporters or encouraging release.
Makes sense. Okay, one more potential factor people always ask about. Diet. Does what you eat cause or affect ADHD?
Ah, the diet question. Generally, the consensus in these sources is that diet is not a primary cause for most people with ADHD.
So cutting out sugar won't cure it.
Probably not for the vast majority. Now, there might be a small subset of individuals who are sensitive to certain food additives or maybe specific foods, but it's still a bit debated, and the evidence isn't super strong or widespread.
So not the main driver.
No. The Nelson textbook actually advises against putting a huge amount of effort into restrictive diets unless there's really strong specific evidence for that individual. The focus really stays on that interplay of genes, environment, brain structure, and chemistry.
And it all comes back to, as Stat Pearls emphasized, ADHD being a clinical diagnosis.
That's right. There's no blood test, no standard brain scan. It's about assessing the symptoms, the history, the impact on functioning. It's understood as a difficulty with executive functioning, rooted mainly in the frontal lobe, activity, attention, focus, decisions, emotions.
Got it. Okay, let's switch gears now. Who actually gets ADHD? Let's talk epidemiology. How common is it?
Okay. Worldwide, the Nelson textbook puts the average prevalence for school-aged kids somewhere between 5 and 10%.
5 to 10%? That's quite a few kids in an average classroom.
It is, but keep in mind, those numbers can really bounce around depending on the country.
Why the variation?
Likely differences in how studies are done, maybe the exact diagnostic criteria being used, cultural factors. Lots of things could play a role.
Okay, what about gender? We hear a lot about boys and ADHD.
Yeah, there's definitely a gender difference in diagnosis rates. It's diagnosed more often in males. The ratio is roughly 4 boys to 1 girl for the hyperactive impulsive type.
Okay.
And maybe closer to 2 boys for every 1 girl for the predominantly inattentive type.
So still more common in boys, but girls definitely get it too, maybe just presenting differently sometimes.
Exactly. The inattentive type is seen more frequently in females compared to males. It might be missed more easily sometimes.
So it's not just a boys' disorder. Good to clarify. What about intelligence? Is there a link between IQ and ADHD?
That's interesting. According to the Nelson textbook, kids with high IQs are just as likely to have ADHD as kids with average IQs.
Really? So being smart doesn't protect you from it?
Doesn't seem to. However, they do note that kids with lower IQ scores have a somewhat higher chance of also having ADHD, so there's a bit of an association there, but high intelligence doesn't rule it out.
Interesting nuance. Now, we also had that study looking specifically at adult ADHD prevalence in India. What were the takeaways there?
Yeah, that was fascinating. The review part found a huge range reported across different studies in India, anywhere from maybe 5.5% up to over 25% in some populations.
Wow, that's a massive range.
It is. Suggests we need more consistent research, maybe. Then, their own study, focusing on young adults in the Delhi NCR region, found about 14% screened positive for ADHD.
14%. That's substantial.
Definitely. And they found some interesting potential correlations, too. People with South Indian origins and those whose mothers had higher education levels seemed more likely to screen positive.
Higher maternal education linked to higher risk. That seems counterintuitive sometimes.
It does, doesn't it? And conversely, lower socioeconomic status seemed to be protective in this group. It really highlights how complex the factors might be, maybe involving reporting biases, access to diagnosis, or other cultural elements.
Absolutely. Lots to unpack there. But clearly, adult ADHD is a significant issue in India, just like elsewhere. And we heard the inattentive type might be more common in females there, too.
Yes, that pattern seems consistent across different populations mentioned.
Okay. Now let's tackle a topic I know is on everyone's mind, screen time. We've got several PubMed articles on this. What's the connection, if any, between screen time and ADHD?
Right, the screen time question. Well, the meta-analysis we looked at pulled together data from many studies. It found a significant link, yeah.
Significant how?
Children who spent 2 or more hours a day on screens had roughly 1.5 times higher odds of having an ADHD diagnosis compared to kids with less screen time.
1.5 times higher odds. That sounds like a real connection.
The researchers concluded that, yeah, excessive screen exposure might actually contribute to developing ADHD symptoms, not just be a result of it.
Might contribute. And then there was this study following Canadian teenagers over time, a longitudinal study.
Yes, that one added more depth. It found that within a given year, if a teenager's screen time increased, their ADHD symptoms also tended to get worse during that same year.
So it's not just that kids with ADHD use screens more, but more screens might worsen symptoms.
That's what it suggests. And this held true even when they accounted for underlying individual differences. Crucially, they identified impulsivity as a key factor linking the two.
Impulsivity. How so?
It seemed to mediate the connection, meaning increased screen time might lead to increased impulsivity, which in turn shows up as worse ADHD symptoms. This link appeared both within individuals over time and when comparing different individuals.
That makes a kind of intuitive sense. And did they look at specific types of screen time?
They did. One specific finding was about social media use. It seemed to have a sort of delayed or lagged effect on ADHD symptoms, and again, impulsivity was the mediator.
A delayed effect, like using social media today impacts symptoms later.
Potentially, yeah. The idea is it might specifically impact things like response inhibition, the ability to stop yourself from acting impulsively.
Wow. That's concerning given how central social media is for teenagers.
Yeah.
What about younger kids? There was a survey in China with preschoolers.
Right. That one found an overall association, more screen time linked to more ADHD symptoms, with an odds ratio around 1.8.
Even higher than the meta-analysis number.
A bit, yeah. But when they broke it down by gender or when they excluded kids who were overweight or obese, that significant link kind of disappeared.
Oh, so it's more complicated in preschoolers.
It might be. It suggests other factors, like maybe weight or something related, could be playing a bigger role or interacting with screen time in that very young age group.
So the takeaway seems to be, there's definitely a link between higher screen time and ADHD risk or symptoms. But the exact relationship, especially causality and how it works in different age groups or with different types of media, is still being figured out.
I think that's a fair summary. It's likely complex, probably bidirectional to some extent, and needs more research, especially long-term studies.
Right. Okay, let's move on to how ADHD actually gets diagnosed. What's the evaluation process like?
For kids, as our sources lay out, it really hinges on getting a detailed history. A clinician needs to confirm at least 6 out of the 9 DSM-5 symptoms for either inattention or hyperactivity impulsivity.
6 out of 9.
Right. And critically, you need information from multiple people, usually parents and teachers. They often use standardized rating scales, like the Vanderbilt scales, to get this info systematically.
So you get perspectives from different environments?
Exactly, because the symptoms have to be present and causing problems in more than one setting, like we talked about home and school, for example.
Okay. And for adults, you said it can look different. How is the evaluation different?
Yeah, for adults, since the hyperactivity might be less obvious, the evaluation often involves looking back at their childhood history for symptoms, alongside understanding their current struggles. There are also specific rating scales designed for adults, like the Brown Attention Deficit Disorder Scale, that capture those more common adult challenges like organization, time management, emotional regulation.
And interviews are important too.
Oh, absolutely. Clinical interviews are crucial. They dive deep into the person's whole history, developmental milestones, school performance, social skills, mood, sleep, family history of ADHD. It's about building a complete picture.
Right, pulling all the threads together. You mentioned rating scales like the Vanderbilt or Connors. How helpful are those?
They're very helpful tools. They give a structured way to gather information about symptom frequency and severity across different settings. They can also help screen for other conditions that often co-occur, like anxiety or oppositional defiant disorder.
Co-occurring conditions.
Yeah.
Like comorbidities.
Exactly. And these skills aren't just for diagnosis, they're really useful for monitoring treatment response too. You can track scores over time.
Is there a specific score change that means treatment is working?
Often, a drop of 25% or more in symptom scores is considered a significant improvement. But, as the sources rightly stress, the ultimate measure is functional improvement. Is the person actually doing better in their daily life? At school, at work, in relationships.
That makes total sense.
Yeah.
It's about real-world impact, not just numbers on a page. What about physical exams or lab tests? Do they play a role?
Not usually for the primary diagnosis of ADHD itself. A physical exam is important mainly to rule out other medical issues that could mimic ADHD symptoms or contribute to them.
Like what, for example?
Things like thyroid problems, maybe hearing or vision impairments, certain neurological conditions. And a cardiac checkup, looking at heart health, is especially important if medication, particularly stimulants, is being considered.
Right, because of potential side effects.
Precisely. But routine blood tests or brain imaging like MRI or CT scans, not recommended for diagnosing ADHD. It remains a clinical diagnosis based on behavior and history.
Good to clarify. It's not something a simple test can find. Okay, let's get to the really crucial part. Treatment and management. What works? What do the experts recommend?
So medication, both stimulants and non-stimulants, is definitely a primary treatment strategy and often very effective.
But not always the first step, especially for younger kids.
That's right. For preschoolers, kids aged 5 and under, the first-line recommendation is actually evidence-based behavior therapy, specifically parent training and behavior management, and maybe teacher training too.
Behavior therapy first.
Yes, medication might come into play for moderate to severe symptoms in that age group, but only if behavioral approaches aren't enough or aren't available.
Okay. And for kids 6 and older and adolescents?
For that group, ADHD medications are often considered first line, usually alongside continued behavioral therapy and educational support. So it's typically a combined approach.
A multi-pronged strategy.
Exactly. Tailored to the individual's age, symptoms, and needs.
Let's talk more about the medications. Stimulants are the most common, right? How do they work again, and what are the key things to know?
Right. Stimulants like methylphenidate brand names, Ritalin, Concerta, and amphetamines like Adderall or Vivance. They work mainly by boosting dopamine and norepinephrine levels in the brain.
By blocking that reuptake process we talked about.
Yes, blocking reuptake, and amphetamines also directly stimulate release. They're pretty effective, work well for about 70% of people who try them.
70%, that's a good success rate.
It is. They come in different formulations, immediate release that act quickly but wear off faster, and extended release that provides smoother coverage over the day.
And the downsides? Side effects?
Common ones can include changes in blood pressure or heart rate, decreased appetite, trouble sleeping. There's also a potential for misuse or diversion, which needs careful management.
Right. But you also mentioned something interesting earlier, that treating ADHD with stimulants might actually lower the risk of substance abuse later.
Yes, that's an important finding from research. While there's a potential for misuse of the medication itself, overall, successful treatment seems protective against developing substance use disorders down the line.
That's counterintuitive but really important. What about safety concerns, like with seizures or tics?
Recent evidence suggests stimulants are generally safe for people with well-controlled epilepsy. And while they can sometimes worsen tics, other medications like alpha agonists can often help manage those if needed.
Okay, reassuring on those points. So if stimulants don't work or aren't suitable, what are the non-stimulant options?
Good question. Atomoxetine, brand name Strattera, is a main one. It's a selective norepinephrine reuptake inhibitor, works differently than stimulants.
How effective is it?
Generally considered less potent or immediately effective than stimulants, but it can be a really good option for people who don't tolerate stimulants, have significant anxiety alongside ADHD, or where there are concerns about stimulant misuse.
Okay.
Any others? Some antidepressants, like bupropion, are sometimes used off-label. Older ones, like tricyclic antidepressants, are usually more of a last resort due to side effect profiles. Then there are the alpha agonists, clonidine and guanfacine.
Alpha agonists, what do they do?
They can be helpful, especially for hyperactivity and impulsivity, and sometimes with sleep. They seem particularly useful in younger children. But they can cause sedation and lower blood pressure, so you have to watch that.
And these non-stimulants, they take longer to work.
Yes, that's a key difference. Unlike stimulants, which often work within hours or days, non-stimulants like atomoxetine or the alpha agonists can take several weeks to reach their full therapeutic effect.
Good to know. Patience is needed there. Now, beyond medication, what about the non-medical side? Therapy, behavioral strategies.
Hugely important. Psychoeducation, just helping the person and family understand ADHD, is foundational. Then things like cognitive behavioral therapy, or CBT, can teach practical skills.
Skills for what?
Coping mechanisms, organizational strategies, time management, emotional regulation, things medication doesn't directly teach.
Right. So medication helps the brain focus. Therapy helps you use that focus effectively.
That's a great way to put it. While medication alone can be very effective for core symptoms, combining it with these psychosocial supports usually leads to the best overall outcomes, achieving those functional goals we talked about.
And for kids, parent training is key.
Especially for younger kids, yes. Training parents in specific behavioral management techniques, setting clear rules, positive reinforcement, consistent consequences is often the first step. And even with older kids and teens, behavioral strategies at home and school remain crucial.
What about school supports? What can schools do?
Schools can do a lot. Simple accommodations like preferential seating away from distractions, clear expectations, frequent check-ins, allowing short movement breaks.
Practical things.
Yeah. And using positive reinforcement. For some kids, more formal supports are needed, like an individualized behavior plan or even an IEP, an individualized education program, if they have coexisting learning disabilities.
IEPs for more specialized help.
Right. And explicitly teaching organizational skills, planning, time management, those executive function skills that can be incredibly beneficial too.
It sounds like a real team effort is needed.
Absolutely. And a crucial part of that is educating the child and family about the treatment plan, especially medications. Understanding the benefits, the potential risks, side effects, the importance of taking it consistently, safe storage, all that is key.
And monitoring is essential too.
Yes. Regular checkups to monitor height, weight, pulse, blood pressure, especially with stimulants, and screening for any heart issues before starting stimulants is standard practice.
Makes sense.
Well,
Okay, let's zoom out and think long term. What's the prognosis? What does the future typically look like for someone with ADHD?
it's variable, honestly. Symptoms often do persist into the teenage years, and they can definitely impact social life and school performance.
Do symptoms get better with age?
For many, yes. The more overt hyperactive symptoms tend to decrease the most as people move into adulthood. Maybe about half see a significant reduction in overall symptoms.
Why is that? Any theories?
Couple of ideas. Maybe the long-term impact of stimulant treatment on brain development plays a role, helping those frontal lobe functions mature. Or maybe adults get better at choosing environments, jobs, lifestyles that fit their strengths and minimize their challenges.
Self-selection, kind of.
Could be part of it. And we know treatment helps more broadly, too. Treating ADHD can improve symptoms of related conditions like ODD or conduct disorder, and as we said, lowers the risk of substance use.
And the flip side, if it goes untreated.
Well, that's where we see the potential for more long-term dysfunction. Difficulty maintaining employment, higher rates of accidents, financial problems, legal issues, substance abuse. The consequences can be pretty severe.
So ongoing management is critical.
Absolutely. Regular follow-up, continued patient and family education, adjusting treatment as needed. That's essential for long-term success. Think of early detection and treatment as secondary prevention, preventing those downstream negative effects.
It's encouraging to know that it's often very treatable, even though, as the sources mentioned, there's still stigma, and sometimes people might not stick with treatment or chase unproven alternatives.
Right. Stigma is still a hurdle. But when properly diagnosed and treated, lives can be dramatically improved. Providers really should feel confident considering effective treatments like stimulants when appropriate, given their track record when used correctly.
And that interprofessional team approach you mentioned earlier sounds vital.
It really is. Having the pediatrician or family doctor, maybe a psychiatrist or psychologist, teachers, therapists, even the pharmacist, all communicating and working together with the individual and family, that gives the best chance for optimal outcomes.
Because without that, and without good follow-through, the outlook can be more guarded.
Unfortunately, yes. Non-compliance with treatment is a challenge. But the treatments we have do help many people function much better. It's just crucial to get the diagnosis right and stick with an evidence-based plan.
This has been a really comprehensive deep dive. So to quickly recap the big points, ADHD, it's a real recognized neurobehavioral condition. It's got strong genetic roots, but environment plays a role too. It affects attention, hyperactivity, impulsivity, often throughout life.
Diagnosis is clinical, based on history and symptoms in multiple settings.
Right. And treatment usually involves a combination of medication and behavioral or psychosocial strategies tailored to the person. And we also touched on that interesting, still evolving picture around screen time potentially playing a role.
And crucially, early identification and intervention seem key to improving long-term outcomes and heading off some potential difficulties.
Absolutely. So thinking about everything we've discussed, this evolving understanding, the influence of modern life, like screen time, makes you wonder, doesn't it?
Yeah.
What further questions does this raise about how we can best support people with ADHD across their lifespan?
Yeah, what's next?
Maybe it sparks thoughts about reducing stigma in society, or where future research should focus, or perhaps it connects with personal experiences for our listeners. Something to think about. Thank you so much for joining us for this really important discussion here on The Deep Dive.